Good afternoon. Thank you for having me here, and I'm particularly delighted to be on this particular panel with these speakers. I've really enjoyed your comments, and I get to play cleanup, so that's good. Batting fourth. So my clinical work is in infectious disease and geriatrics. So what I think about with genomics is probably very different. It evokes very, very different thing than my oncology colleagues. And today we've heard perspectives from patients, we've heard perspectives from providers and systems, and we've heard about geography as destiny and facilitators of care and also many barriers to care. And I'm looking forward to hearing about innovation in the next section. So what I'm going to do is really address this question, which is what is the role that large employers can play in efforts to address health disparities and improve access to care, both sort of in general and then also keeping genomics in mind. And I'm going to approach the discussion today wearing my Chief Health Officer hat. And I'm very proud to be the Chief Health Officer for the University of Michigan. And people always ask me, well, what do you do with that? And I am the key advisor to our president on all matters of health and wellness across campus. So everything from students and student mental health and partying too much to issues on faculty and staff, including the benefits office, which I have learned a lot from my colleagues there. And like many large employers, the University of Michigan is self-insured. And this provides some flexibility in terms of how things might be structured and what types of services may or may not be covered. We've always had a really good benefits plan, even before ACA. I think very generous in terms of prevention and care. Some unique things about Michigan is that we're also a provider of healthcare. We're a very big academic medical center, Michigan Medicine. And we're also a big academic university with 19 schools and colleges. We have 7 health sciences schools along with engineering, business school, public policy, and there are hundreds of people on the faculty who are interested in health services research. So this gives us a really great opportunity to think about innovation, to try things out, to measure them, and to report them. And I'm going to show you an example of this later in my comments. So I want to start with just why employers are important partners in this discussion. And I think, again, there are probably 2 big reasons. One is, the more obvious one, is that a lot of adults rely on employers for their health coverage. Overall, across the country, it's about 50%. If you look at adults under 65 who generally wouldn't have Medicare, it's higher, and it's higher in some states. And from the employer side, and particularly being a self-insured entity, there is a economic reason why you want your employees to be healthy. Healthy employees are productive employees, and doing the right thing now can pay back very big dividends down the line. And I have to say that I didn't really think about that issue as much until I came into this role last year, and that the idea that employee health, not the kind I go to get my TB test, but the health of employees is so critical to businesses, and that just like kids spend time at school, where do adults spend their time? They spend it at work. And so all the employee wellness programs are not just nice things, but they're actually really important economically. And for us at Michigan, health insurance is pretty equitable. Like, people have access to the same really high quality, excellent products. But like many places, use is not equitable, and use is not, the patterns of use are different. And I'll show you some of this. And there are lots of reasons for inequity, and we've touched on many of them today. And for the purposes of my comments, I'm going to focus on wage and looking at particularly our low and high wage workers and how they differ in terms of care usage. Because again, socioeconomics is a bit of a common thread in all of this discussion. So this is a study, and for those of you who are following along on Twitter, I did tweet out the full link to the study a little earlier. This is from Bruce Sherman, who's in Cleveland. This was published in Health Affairs last year, and it is data from 2014. And they looked at spending across almost 43,000 employees who were employed by 4 large companies. And these were self-insured companies, and they looked at just patterns of care usage, what it cost to cover these individuals. And they divided the population up into 5 groups by wage, with the lowest being less than $24,000 a year income, and the highest being greater than 70, and then the three in between. And what they found was that when you looked at the low wage compared to the top wage, and again, these were numbers that were adjusted for age and for other key demographics, is that the low wage workers had about half the usage of preventive care at 19% versus 36%. They had about twice the hospital admission rate, and these are rates per 1,000 individuals, 31 versus 17. Very important, they had 4 times the rate of avoidable admissions. So again, these are sensitive conditions. If you had been seen in primary care sooner, you might have avoided an admission, 4.3 to 0.9, so about 4-fold. And also 3 times the rate of emergency department visits at 370 visits per 1,000 to 120 per 1,000. Now, we were interested in looking at our numbers from Michigan, and I'll show you those here. And these are courtesy of my colleague, Christy Jenkins, who works with me on our employee health, and John Ianian, who is our director of our healthcare Institute for Healthcare Policy and Innovation. And we looked at the number. We just did a straight cut. We didn't adjust for age and things. And we have about 50,000 employees and about 100,000 lives. And not all of them are included here. But when we looked at people who made less than $35,000 a year versus those above, the payments were pretty close, $4,200 versus $4,075. Pharmacy payments were pretty similar too, and the total payments were within the ballgame, and they were close to Bruce Sherman's numbers. Where we saw differences was again in the type of health care that was used, and again you can see here the preventive care was lower, other visits were higher. I think it's really important to note that mental health and substance use visits were lower, and again Brian touched on this with his comments regarding Henry Ford and some of the barriers there. And again, these are people who have similar insurance products. So again, that is not the barrier here. There are many other barriers. Emergency department visits, much like the national data from Bruce Sherman, was much, much higher. And as were inpatient admissions and the number of inpatient days. So this was concerning to us. And again, what does this mean? What we've done with some of these numbers is we've taken some of our employee health initiatives, and we call it M Healthy, Block M at Michigan. We have a lot of good programs beyond just being active and eating well. We're finding that people aren't always engaging with them, and so we've taken some of this data and gone to, particularly within the health system, one of the sites that has a lot of workers that also live in a community that's very vulnerable. And so instead of saying come to a cooking demo on campus, we're going there with the cooking demo. We're going there with the fresh produce. And we're trying to build a partnership there, and then hopefully we'll be able to touch on other more serious health issues as we build that community. And I know some people have made good comments about that, about not just being able to drop in and say, here, you need to go get genomic medicine, but rather starting with some basic things. So, and again, just to summarize our numbers, which I pretty much did in my comments, lowest and the low and high income workers had pretty similar total healthcare spending. The lower workers had fewer preventive services and visits. Lower income workers used fewer mental health and substance use visits, substantially more emergency department visits, and more inpatient services. So again, really concerning from an employee standpoint to see that, and we're building a more comprehensive strategy to deal with that. So this is the question I have, is can thoughtful benefit design help address access and equity? And I want to share a recent example from the University of Michigan. It's not a genomics example, but it is an example of something that cost a lot of money and that was not available to everybody, and it was resource intensive, and that is in vitro fertilization. And this is work that was done before I came into this role, and I'm going to show you some data from my colleagues who've done the evaluation piece on this. So back in 2013, there was a graduate student at the University of Michigan who asked about IVF services. We all sort of take it back to this one request, this one voice saying, well, why don't we have this? And it launched some discussions internally, like, well, should we have this, and what do other people offer? And what ended up resulting was a big discussion within our Medical Benefits Advisory Committee, which is a multidisciplinary group, clinicians, bioethicists, lawyers, people on the benefits side, HR. And we brought in experts from urology and OBGYN to just get information on this. And they ended up deciding to do a 3-year pilot. Say, well, we're going to try this for 3 years. Let's see how it goes. And what they did is they set some rules ahead of time. And I think I'm presenting this because I think it's important to think about how you can do things creatively sometimes when you have control of the insurance and, in this case, the provider side. They limited the IVF to women that were 42 years and younger. So that was important, and there was an education piece to the primary care community to make sure, refer women early. Don't wait till they're 43. Try to get them in sooner. They also set out clinical rules, and this was with guidance from the Reproductive Endocrine Society and with our clinician experts to use 1 embryo in women less than 35 and a maximum of 2 for those between 35 and 42. There was a lifetime benefit set at $20,000, which doesn't sound a lot, but it actually was sufficient for most people. And there was a 20% co-insurance that was included. And the decision was made to use an exclusive network and to direct the care all back to Michigan Medicine, which hasn't been done with any other service, but in this case they did it because it was a little bit different and it was a little bit risky and it was very innovative. And this is sort of what they found. And I'm going to shout out to my colleague, Jim Dupree, who's one of our urologists. He did this work alongside with his colleagues in public health and OBGYN. And I'll just take you through a couple of these slides. They came up with a really complicated algorithm that was very good at predicting what women had IVF because it wasn't a claims-based since it wasn't paid for. So in 2012, 2013, 2014, you can see the overall numbers were what they are. And once the policy went into place, the numbers went up. Not surprisingly, they went up a lot. And some of that care may have been just people getting care elsewhere, but this was all at the university. But the important thing wasn't so much that care went up, it was how it went up. And it went up greatest in the lowest income bracket. And these are income bands, low, middle, and high, and the high is 50% and above. And he came up with these numbers, 13-fold, 12-fold. Again, you can see that there's a big increase. And I want to point out, too, that in all the salary groups, the rate of IVF uptake went up to where the high-income group was before. And I think that's pretty incredible. I sort of get chills when I look at it because we talk about equity. I think this, to me, is equity. And in fact, this is my last slide. If you look at the data a little bit differently, pre-policy, only about 6% of the lowest income, the share of IVF by premium group was 6% in the lowest income group, 28% in the next, and then 65% in the high income group. And it ended up shifting to where it mirrored it almost exactly. And I think it's a good example of how you can do things thoughtfully and you can do things in a way. They did this 3-year pilot and we'll probably continue it because it was going well. So I just have a couple take-home messages. One is that there's a compelling economic case for employers to be at the table, to be partners to all of you. Obviously the University of Michigan's a little different because we're also a big health system, but a lot of the big sort of traditional corporate partners are also very, very invested in this. Simply having good benefits and access is not enough, and we've seen that over and over today. And we see this with preventive services. And in fact, we're talking about genomic medicine, and we're talking about access to the latest technology, and we can't even get people to get colonoscopies because they don't have a ride home. So I think that part of it is really having a very broad view on this and trying to address the issues in a very holistic way. And then finally, I just want to make a comment about the Medical Benefits Advisory Committee. Most companies have some sort of committee like that. And again, if they're not a medical school like we are, they probably bring in expertise from outside. But for us, that is where all these discussions happen. Thank you.